Then we're going to move on to the next presenter. That is, it actually says incorrectly here, associate professor. He's actually been quite recently promoted to full professor, Mark Oyama of University of Pennsylvania at Department of Clinical Science. Mark is a person who's published a lot in the veterinary fields. I'm sure you're all aware of his work, in particular of biomarkers, and also very interesting work with molecular genetics and protein expressions in different diseases. I think that's fascinating work. And you know that he has published quite an impressive number of papers over the years, and is a frequent presenter also at different conferences. So, Mark.
Thank you, Jens, and thank you to SIVA and for all the attendees here. It's quite an honor for me to present to a very distinguished crowd, as well as many people whose papers we've all read in Journal Club and really admire. So it's a great honor for me to present in this section. I will have to say that my heart did a little pitter-pat when I heard Dr. Force say he doesn't care about risk stratification, because as you'll see here on my first slide, I love risk stratification. And so what I'm going to try to hopefully convince you is to put the veterinary spin on why I think, at least in our population, some of the data that's now emerging about risk stratification does have a possibility to impact the way that we treat our patients. So as Dr. Force very elegantly pointed out to us, there are many possible uses for markers, but in the context of the disease that maybe we most care about, particularly in dogs with mitral valve disease, we can start to think about how important these markers are for our everyday clinical practice. And I would submit to you, and I think I would get some general consensus, that as a diagnostic tool, we really don't need any markers. We have auscultation, and we know that in older small breed dogs, if they have a left-sided apical murmur, it's going to be mitral valve disease. And we know that we can do ultrasound and radiographs to get a very good idea about disease severity. So in that context, we're not that as excited about biomarkers as in other diseases. In the context of diagnosis of heart failure versus respiratory disease, there's been now many published papers on the veterinary side showing that there is a utility here, and similar to what they've seen in people, the test is best used as a rule-out test, so a low value indicating that there's a high likelihood that it's not going to be congestive heart failure, both in the dog and the cat. And so I would submit to you that maybe the point of evolution where we're at here in veterinary medicine is very much now starting to look at risk stratification. And so I will hopefully convince you of that here in the next 20 minutes or so. So the way that I kind of view biomarkers would be, along the course of disease progression, can the marker tell us when to intervene? At what point is it appropriate for us to intervene so that we could alter disease progression, slow it down, or maybe even if we think really big, to actually mitigate or reduce disease progression. And so we've started now to see some studies that have told us about risk stratification, and this is the study that I'm sure that many of you are familiar with from Adrian's group, which is really one of the first ones to demonstrate that a blood-based marker, neurohormonal marker, can be used to stratify risk in dogs with mitral valve disease. And there were similar publications that came out from the French group at Maison Al4. Now, in thinking about other biomarkers that we could use in conjunction with BNP, so again, speaking to the multi-marker therapy, I think it would be relatively naive for us to think that one marker is going to give us all the information. We don't look at just ALT to figure out about liver function. We look at a panel of markers and use that information collectively together to give us actionable sort of information. So if we start to think about the main players in dogs with mitral valve disease, at least, we can think of the myocyte, the valvular interstitial cell, and certainly the extracellular matrix of both the valve and the myocardium. And clearly, there's a relationship between all of those components. And we can think about then the way that those components change so that they all conspire to lead to progressive degeneration, secondary changes within the myocardium, eccentric hypertrophy, the vicious cycle of regurgitation begets regurgitation, and eventually signs of congestion. And so for those of us that are interested in biomarkers, for instance, if we look at that list that Brunwald published, we can start to think about, well, which biomarkers might be players in dogs with mitral valve disease. And there's been a variety of different publications over the years looking at specific markers. So NT-proBNP we're very familiar with. Other things have been published about the matrix metalloproteinases, et cetera. But this would maybe just be a partial list of some things that contribute to the various pathophysiologic mechanisms that are all going to contribute to degenerative valve disease. So the objectives here of my talk to you is I am going to present just very briefly a selection of 8 different markers that we've looked at to try to get some additional information about both pathophysiology and maybe their diagnostic and prognostic potential in dogs with heart disease. So I'll show you some of the pilot results of that. And then I'm going to try to convince you, at least for one of those markers, that by looking at the way that it might stratify risk for first onset of congestive heart failure, that at least gives us the chance then to think about intervening and changing the course of that animal's progression of disease. So that's my objectives here. So for the next couple of minutes, I hope you'll indulge me. I'm just going to run through the markers that we've looked at so far in dogs. There's just one slide each for each of the markers. So Dr. For's already mentioned classes of markers. So this would be a marker that would be in remodeling or / fibrosis, and it's galectin-3. It's produced by macrophages, and it's involved in myocyte and valvular interstitial cell proliferation and fibrosis. And there are studies in people showing that it adds value to existing markers, namely BNP, to predict mortality. So again, this is a Kaplan-Meier curve with death or recurrent heart failure on the y-axis. And although it's relatively hard to see, this bottom maroon line here is the survival curve in people that have both markers elevated. And it's significantly higher than in people that have either only one marker elevated or neither marker elevated. So in conjunction with BNP, it adds additive value to prognosis. And we would be correct in saying this is interesting information, but for any individual patient, or for us, dog that walks into the room, we have no idea in terms of this survival curve, even if they're elevated, where are they going to fall? Are they at high risk or low risk? So I would agree that as a population study, this data isn't necessarily going to change the way you treat patients. The question is can we fine-tune this so that now we can look at individual patients and adjust treatment accordingly? We also know that in addition to changes in fibrosis, the activation of the sympathetic nervous system is a hallmark for animals with congestive heart failure. And so one marker that's been proposed is something called chromogranin A. And it's a precursor of vasostatin, and it's released by nerve terminals that are either peripheral or central. And again, similar to the data I showed you for galectin, patients that have high chromogranin and BNP, so that's the box in the back, we're looking at risk ratio on the y-axis for 1 year all-cause mortality. Those patients that have both markers elevated have higher risk than either one marker elevated or neither marker. Maybe germane to this particular conference is osteopontin, and that osteopontin is one of the molecules that's the effector molecule, I guess, of aldosterone. So it mediates some of the changes in the extracellular matrix and fibrosis that's brought on by aldosterone. So it's actually a cytokine, and so its other name is cytokine ETA1. And it's been shown in a number of studies, particularly in the rat model, that it basically works with angiotensin and aldosterone to mediate fibrosis within the myocardium. Another marker is soluble ST2, and this is actually a receptor for interleukin-1, and it can come in two different forms. It's normally bound to the membrane, where it actually has a protective effect. This membrane bound cycles back and forth between a soluble receptor out in the circulation, where it's not able to be bound by interleukin-2 and have its protective effect. So soluble ST2 would actually be a negative sort of circumstance. And again, it can be combined with BNP to show that people are at higher risk. Two other ones I'm going to show you here. One is called endoglin, and a recent study in people have shown that intervention with diuretics to treat congestive heart failure causes a decrease in the marker, and it actually mirrors decreases in pulmonary capillary wedge pressure very, very nicely. So this would be a marker that would maybe speak to response to treatment. You go in, you would give diuretics to an animal, and you want to know, are you giving sufficient diuresis above and beyond resolution of their clinical signs? And perhaps a biomarker would help guide you in that therapy. And then finally, a marker that we've known for a long time, and that's cardiac troponin. We know that it's a marker of cell damage and necrosis, and that it increases as severity of disease increase. So this is showing you cardiac troponin versus increases in left ventricular end diastolic dimension from Dr. Lungwell from Sweden. And the final thing I would say is that it's very likely that we're going to have to add BNP on to other things. And so this is a very, I think, exciting paper that Peter Lord has just published online from JVIM, showing that the rate in rise and increase in the vertebral heart size is a marker for impending congestive heart failure. And so as you go from left to right there are animals that are getting closer and closer to heart failure in that last final column. And you can see, for instance, that the heart size stays relatively constant until the period of time just before heart failure. So I suspect that it will be a combination of various things that can be used to stratify risk in these particular dogs. So with that, I'd just like to acknowledge the group from Henry Ford Health Systems and also our cardio residents, and in particular Corinne Reynolds, who kind of headed up that PREDICT study, the results of which I've just shown you. So thanks for your attention. I appreciate it.